So I think it's 8 o'clock, and we'll go ahead and get started. Welcome to High Rounds today. We actually have two speakers today that I'll introduce. First of all, Dr. Amutha Rajagopal. We call her Amu. She's an infectious disease physician who cares for patients with HIV, hepatitis C, and opioid use disorders. She mainly works at UCSD Owen Clinic, but also consults on hospitalized patients with complex infectious diseases. She did her medical school here at UCSD and did her ID fellowship at the University of Chicago. So Dr. Rajagopal is going to present first, and then it's going to be followed by Dr. Jessica Montoya. And Dr. Montoya is an assistant professor in the Department of Psychiatry here at UCSD. She's a clinical psychologist at the Owen Clinic and a consultant of the UC San Diego Dissemination and Implementation Science Center. She has a K-23 mentored patient-oriented research career development award funded by NIDA titled an integrated incentive-based treatment to optimize HIV treatment engagement among persons who use methamphetamine. Broadly, her implementation science research focuses on identifying and evaluating strategies for implementing evidence-based practices for substance use disorders in HIV care clinics. The title of today's presented talk is called Novel Approaches for Treating Methamphetamine Use Disorder, Medication-Assisted Treatment, and Smartphone-Delivered Contingency Management. So I think we're going to start with Dr. Amu. So go ahead and take it away. By the way, I will be monitoring the chat pod today, and they've been asked we'll take questions probably at the end, just because there's quite a bit to discuss today, but I'll monitor the chat pod. All right, Amu.
Okay. Good morning, everyone. So I'll be presenting a brief introduction to methamphetamine use disorder and any evidence-based medical treatments. So in recent years, amphetamine-type stimulants have been identified as the fastest rising drug of abuse. Around 4.7 million people, or 2% of the population in the US, have reported trying methamphetamine at some point in life. The CDC recorded the largest number of drug overdose deaths ever during the 12-month period ending in August of 2020. And this was over 88,000 deaths. Overdose deaths increased during the COVID-19 pandemic, highlighted in dark red. So fentanyl remains the top cause of drug overdose deaths nationwide, accounting for nearly 40% of them. However, patterns of drug use differ by region in the country, and methamphetamine has actually emerged as the leading cause of drug overdose deaths in Western and Midwestern parts of the US. Cardiovascular complications are the leading mechanism of death among methamphetamine users. Fentanyl contamination has also, however, become a growing risk for fatal methamphetamine use, particularly in opioid-naive users. And rates of suicide attempts and completed suicide are also significantly higher in amphetamine users. Aside from morbidity and mortality numbers, methamphetamine use also has significant intangible social, employment, legal, and economic costs. Even in 2005, it was estimated that annual costs of methamphetamine-associated treatment, healthcare usage, productivity losses, crime, and child endangerment amounted to over $23 billion in a year. And this chart from the DEA's website just shows that methamphetamine is also the drug of abuse that contributes the most to violent crime in the United States. Just to provide some historical context to the current epidemic, amphetamine is thought to have been first synthesized in the late 1800s in Japan. It was first introduced in pharmaceutical formulations, mainly for nasal congestion, asthma, narcolepsy, and weight loss beginning in the 1920s. And then interestingly, amphetamines were widely used by the German, Japanese, and American forces during World War II as drugs that were noted to increase alertness and decrease fatigue. After World War II, use increased dramatically, while federal restrictions became increasingly tighter on amphetamine precursors, with the observed health consequences. And the rise of crystal meth, a higher purity form of methamphetamine that was significantly more potent and addictive, and unlike cocaine and heroin, could also be made in the household from household products, contributed to the explosion of meth abuse in the US from the 1980s to early 2000s, and really spread eastward from super labs on the West Coast and also from across the southwestern border. In 2005, Congress mandated that pseudoephedrine and other amphetamine precursors be put under a lock and key in stores nationwide. And as a result, appeared that domestic production actually appeared to decrease after 2005. Recently, however, methamphetamine use appears to be on the rise again, with a steep rise in the associated deaths occurring since at least 2015. And most of it is actually currently coming across the border. In recent years, meth abuse has been found to be disproportionately high among men who have sex with men. In the San Diego area, 8.5% of MSM reported using meth within the past year, which was also significantly associated with higher risk sexual behaviors. Meth use in MSM has also been found to double the risk of HIV acquisition. Among HIV positive men who have sex with men, methamphetamine use has been linked to worsening disease outcomes, linked to poor medication adherence and retention and care, with higher plasma viral loads. Also higher risks of infection with hepatitis C and STDs, as well as transmission of HIV. So methamphetamine is a synthetic stimulant that increases monoamine neurotransmitters, most notably dopamine, but also norepinephrine and serotonin in both central and peripheral synapses. And the mechanisms by which it does this are many, but include increasing the activity and synthesis of the enzymes that make these neurotransmitters, increasing the release of these neurotransmitters into the synapse, decreasing the reuptake by decreasing expression of the transporters and blocking the transporters of these monoamine neurotransmitters, as well as inhibiting the breakdown of the monoamine neurotransmitters. The increasing prevalence has been attributed to its low cost and its ease of use, aside from its extremely high addictive potential. So it's rapidly absorbed via many routes, while it is most commonly smoked or snorted and much less frequently injected. The pharmacokinetics can be summarized with fast uptake and slow clearance, really describing its major pattern, but the effects are almost immediate, with peak concentrations occurring within minutes of use. And although it has a plasma half-life of around 12 hours, the duration of its neurologic and cardiovascular effects actually commonly persist beyond 24 hours. The addition of a methyl group to amphetamine actually renders methamphetamine especially lipophilic, resulting in increased blood-brain barrier penetration. And methamphetamine has been found to accumulate in brain in concentrations that are up to 10 times greater than what's measured in the plasma. Furthermore, the enzymatic degradation also actually produces active metabolites, which can accumulate with binge use. And elimination occurs via hepatic and renal pathways. So neuroimaging studies have found evidence that methamphetamine-dependent individuals experience profound changes, particularly in the dopamine pathways in the orbitofrontal and prefrontal cortex. Chronic meth use leads to fewer dopamine receptors and decreased transporter activity, which leads to greater meth tolerance. There's also evidence from postmortem studies that methamphetamine actually causes the death of nerve cells by various pathways, such as increasing or mitochondrial dysfunction and oxidative stress. Importantly, these changes, predominantly in dopamine pathways in the frontal and prefrontal cortex, have been found to persist even after sobriety for several months. while the changes may improve with abstinence, along with a person's memory and problem-solving skills. So this image actually shows how dopamine binding to dopamine transporters, which is highlighted in red in the far left image, is significantly diminished even after 1 month of abstinence in the middle image. And this activity appears to improve after 14 months of abstinence on the far right, while not entirely at baseline. So a sizable subset of individuals, estimated in some studies to be up to 17%, actually go on to develop meth-associated psychosis that persists for months and years after cessation. The DSM-5 includes diagnostic criteria for amphetamine-type substance use disorder, which is having 2 or more of these characteristics within a 12-month period. And these basically describe a person using larger amounts of drug than initially intended, unsuccessful efforts to control use, failure to fulfill major obligations, using despite recurrent social problems, and tolerance and withdrawal symptoms. So most studies of treatments for stimulant use disorders in general have examined patients using cocaine and not methamphetamine. And it's important to know that while these have similar mechanisms, there's major differences which may make the results not applicable. So the reinforcing properties of cocaine are mediated primarily by its blockage of dopamine reuptake, while the effects of methamphetamine are mediated by both the blockade of reuptake and the increased presynaptic release of dopamine, as well as the other mechanisms I had mentioned. Cocaine is also much more quickly removed by the body with a plasma half-life of about an hour compared to the prolonged bodily presence of methamphetamine. So while I'm going to briefly discuss the therapeutic options that have been studied, which are few, it's important to know that only psychosocial interventions, specifically cognitive behavioral therapy and contingency management, have ever proven consistently efficacious for stimulant use disorders, including methamphetamine use disorder, while insufficient. There are currently no FDA-approved pharmacotherapies for methamphetamine use disorder, which constitutes a major gap in our current medical care. But more recently, there have emerged 2 potential, possibly beneficial options: mirtazapine or bupropion and naltrexone in combination. So mirtazapine or Remeron is an FDA-approved antidepressant, facilitates norepinephrine, serotonin, and dopamine release in specific parts of the brain that are involved in drug craving and seeking behavior. So theoretically, this could alleviate methamphetamine cravings and withdrawal. So a group of scientists in San Francisco did a study between 2013 and 2017, which was a small double-blind randomized controlled trial to determine the efficacy of mirtazapine for treatment of methamphetamine use disorder as the primary outcome, as well as reduction in HIV risk behaviors as a secondary outcome. So the participants included sexually active cisgender men, transgender men, or transgender women having sex with men who were actively using methamphetamine and fit the criteria for methamphetamine use disorder. In the intervention, participants were randomized to mirtazapine 30 milligrams daily or placebo for 24 weeks. And then primary outcome was analyzed at 12, 24, and 36-week time points as a positive urine drug test result. So 120 participants were enrolled, 60 per arm. On average, participants were in their mid-40s. About 50% were white, 25% African American, and a little more than half of participants were HIV positive. The most common frequency of crystal meth use reported was nearly every day in both arms. And the intention to treat analyses, the rate of methamphetamine positive urine samples appeared to be significantly lower among participants assigned to mirtazapine versus placebo at each tested time point. However, as you can see in the figure on the right, the vast majority of participants in both arms had positive urine drug screens throughout the study period. By week 24, at the end of treatment, positive urine drug screens were found in 63% in the mirtazapine arm compared to 74% in the placebo arm. And then at week 36, which was 3 months after stopping treatment, 71% of participants in the mirtazapine arm had positive urine drug screen versus 88%, so higher, but still considered a significant difference. And then most high-risk sexual behaviors were reported to be decreased significantly among participants taking mirtazapine compared to the placebo, including number of sexual partners and episodes of unprotected anal receptive sex, also particularly with serodiscordant partners. Participants assigned to mirtazapine also had net reductions in depressive symptoms and insomnia severity, specifically at week 24, but not earlier, consistent with the known use of mirtazapine. And there were no serious adverse events associated with mirtazapine. Importantly, the rates of adherence, as measured by a pill dispenser tracker in both arms, were similarly low, around 40% at 12 weeks and even lower afterwards. And end of study abstinence, which was defined as basically having negative drug screens during the last 2 weeks at a time point, showed no difference between the treatment arms. So in terms of takeaways, in a landscape with really no approved or proven drug treatments altogether, these study results indicate that mirtazapine could potentially help reduce meth use among MSM with benefits extending to 24 weeks and possibly even 36. And that there might be significant reductions in important HIV risk behaviors, however, not until 6 months of treatment with mirtazapine. And then also consistent with its known effects, mirtazapine might help depression symptoms and insomnia issues in patients using methamphetamine. In terms of the limitations of the study, certainly would be poor treatment efficacy and poor adherence in general, with the majority of the participants non-adherent to mirtazapine. So it might be useful to look at longer acting formulations or perhaps pairing this with behavioral interventions in studies in the future. So the second study, a published idea for MAT, emerged more recently, which was bupropion in combo with injectable naltrexone. And bupropion is also an antidepressant, acts through central norepinephrine and dopamine systems. Like mirtazapine could theoretically treat the dysphoria associated with withdrawal that drives persistent use. Naltrexone is an opioid receptor antagonist that is effective for treatment of opioid use disorder and has also been shown to have a modest effect in alcohol use disorder, possibly by attenuating reinforcing effects or cravings for these substances. So this article was published in January of 2021, which described the ADAPT-2 trial. It was funded by the National Institute on Drug Abuse and was conducted at 8 clinical sites from 2017 to 2019. I used a sequential parallel comparison design and was double-blind, randomized, and placebo-controlled. So eligible subjects were adults who met criteria for moderate or severe methamphetamine use disorder and were notably opioid-free at the time of randomization based on urine drug screening. Primary outcome was a response to treatment, which was defined as not one, but at least 3 of 4 negative urine drug screens in the last 2 weeks of the 6-week treatment. A total of 403 participants underwent randomization, 109 to the naltrexone bupropion arm and 294 to the placebo. And the average age of participants was 41, nearly 70% were male, and nearly 70% were also white. And response rates were significantly better with naltrexone bupropion at 13.6% versus 2.5% with placebo for an overall around 11 percentage point treatment effect for having 3 out of 4 negative urine drug screens in the last 2 weeks. Notably, there were significantly more GI adverse events, most commonly nausea, which occurred in the naltrexone bupropion arm, which occurred actually at fairly high rates at about 30 to 40% compared to half of that in the placebo arm. So the authors concluded that among adults with methamphetamine use disorder, there was a low but significant response to extended release injectable naltrexone plus oral bupropion with a 6-week intervention. So in terms of takeaways, again, in a barren landscape, this is another potential option that can be offered for patients if they can tolerate the GI symptoms. The study also includes many patients with severe methamphetamine use disorder, as did the one for mirtazapine, and these drugs are also already available. The treatment option, however, also did not appear to be effective for the vast majority of people who are suffering from methamphetamine use disorder. Both studies also likely had strong selection bias, as they required patients to sign up to come in for weekly or biweekly urine drug screens. Importantly, long-term outcomes are really important, given the very high relapse rate with methamphetamine use following cessation. It's greater than, so majority of people, greater than 60% are estimated to have relapse in the first year. There was also a lower representation of women in these trials. We also don't know about the psychiatric comorbidities, which are common in individuals using meth and could complicate treatment, potentially with drug-drug interactions. And then lastly, concurrent use of opioids was contraindicated with naltrexone treatment regimen and is commonly occurring as well. And this could be a huge issue in the absence of ability to have testing prior to treatment initiation with the increasing prevalence of fentanyl contamination, since naltrexone would precipitate withdrawal. Just wanted to make the point that there's also no uniformity as to what drugs are included in urine drug screens or what the cutoff values of detection should be. And at UCSD currently, we currently do not routinely have a point of care urine drug screen that specifically detects fentanyl up front. Opioid screening tests typically detect morphine, a common metabolite of heroin and natural opiates, but often do not detect synthetic opiates like fentanyl, methadone, or tramadol, or even semi-synthetic opiates. Therefore, using our standard urine drug immunoassay option will fail to detect fentanyl unless other specific opiates are present during the confirmatory testing. So to check for fentanyl, we would need to specifically order a urine opiate confirmatory drug test first here. Personally, I think improving accessibility of fentanyl testing will be essential to first knowing the accurate prevalence of fentanyl contamination locally, offering medication-assisted treatment, but also perhaps most importantly for educating our patients on how to prevent overdose death and encouraging us to prescribe life-saving Narcan. In summary, we clearly need more data and more efficacious ideas for a very urgent problem. There's some evidence that combining psychosocial interventions such as contingency management or CBT, as Jessica's about to discuss, with medication may be more efficacious than either modality alone, at least for cocaine use disorder, but this is yet to really be explored for methamphetamine, which, as I described, is different. We are conducting a small pilot study at Owen Clinic shortly to assess the feasibility and acceptability of using a multi-pronged approach with combined MAT and behavioral therapies for patients living with HIV and moderate or severe methamphetamine use disorders. So more will be coming, hopefully. Now I'll turn it over to Jessica.
Actually, this is Daniel. Can I ask, there are very quick questions, Amu. I think this will be pretty quick. So there was a question about mirtazapine. Did they assess how often the treatment arm patients actually took the mirtazapine?
Yes, it was 28%, so it was very poor adherence. And that's because they actually had a pill, they had a pill dispenser that tracked the adherence. And interestingly, in the bupropion naltrexone study, it was self-reported adherence. So we really don't know how that was, but yeah, and it was very poor in the Remeron study.
Okay. Darcy also asked about the naltrexone. Are there GI side effects with long-acting naltrexone the same as PO naltrexone?
Oh boy, I actually don't know.
Okay.
I'm not sure. Yeah, and part of me wonders if there might have been like opiate use might have been confounding this picture, but with naltrexone causing withdrawal, but we don't know.
Okay. And Robert asked a quick question. Is fentanyl contamination a regional or San Diego phenomenon, or is it really more widespread?
It's more widespread, and it's thought to be driving the steep rise in deaths with fentanyl as well. It's definitely more widespread issue.
Yeah. And then I think that's it. So let's go ahead, Jessica,
Yeah,
and
Sam, I
maybe
actually have one quick question just related
sure.
to fentanyl. With what Darcy just said, how she screened her patient and it came up for fentanyl. My understanding is there's some additional tests that we have to do to make sure that we capture every, all of the metabolites because it may not pick it up. Is that something that we should be standardly doing? And what is that test?
Yeah, so that was the point of my second to last slide, which was basically that it will not show up if you are looking for it specifically unless there's another opiate present that our urine immuno assay is able to detect, most commonly morphine. And yeah, so there's a fentanyl is not like on every urine drug screen as a standard. So ordering a urine confirmatory opiate screen is really important at our facility, especially. Yeah.
So you should order the two concurrently. Is that correct?
You could order both, but you need to order the urine opiate confirmatory test. You could do that alone just to check for fentanyl, just alone. Okay. Yeah.
Thanks.
All right. Go ahead, Jessica. We'll maybe Amu can take a look at the chat pod if she had any other comments to the other comments. So
sounds great. And then I think I'll try to reserve time at the end. So any
great.
Additional questions for either one of us? Okay, well, thank you for the introduction at the beginning. I have no disclosures to report, but I did want to acknowledge my funding sources, particularly the CFAR administrative supplements that are aimed toward increasing the integration of substance abuse services in HIV prevention and care. As Amu stated earlier, we do have some pilot studies that are in the works to really help us better integrate medication-assisted treatments as well as behavioral approaches to the treatment of methamphetamine. So before I dive in, I did want to highlight some principles of substance use disorder treatment that are recognized by NIDA as being evidence-based. And they are the principles that I believe are guiding the work that we're doing at Owen Clinic. So first, as Amu mentioned, if we do offer pharmacological treatments for the treatment of methamphetamine, it is recommended that we do combine that with a behavioral treatment. So that's why today we have this multi-pronged approach of first Amu talking about those pharmacological treatments. And then in my talk today, I'll be talking more about the behavioral treatments. But I also want to recognize that no single treatment is appropriate for everyone. So I will be presenting on the data that supports the use of contingency management, but I do recognize that it's not a treatment that works for everyone. And a lot of work is needed to help us better identify and match people to appropriate treatments. But an important principle is that treatments need to be readily available. So I'm very excited that the leadership at Owen Clinic is working toward further integration of substance use treatments to make it more available more quickly to patients. And then retention and treatment is important. So behavioral treatments, we typically think about this as being 3 months, but for pharmacological treatments, we really want people to be staying on treatment for at least 12 months to confer the best patient outcomes. And even when treatment can't be provided, ongoing monitoring of substance use is critical. And this can be in the form of either just asking patients about their substance use at every clinical encounter, or it could also be through the routine use of urine tests. And I think this crowd knows that treatment should include testing in treatment of HIV and other infectious diseases. So Amu presented a lot of this data already, but I did want to highlight that more and more as the epidemic moves forward, we are seeing that many people who are seroconverting are persistent meth users. So I've provided a citation for a recent publication that has shown that trend. And as many of us, I believe, are aware, meth use does thwart our efforts to end the HIV epidemic. And we see this along the HIV care continuum. But one important thing to be aware of is that for those who do engage in methamphetamine use disorder treatment, we do see 3-fold increased odds of them being more likely adherent to antiretroviral therapy. So I think this is just highlighting the importance that when you do treat substance use, you get better substance use outcomes in terms of reduced use.
Backpack that is perfect for those who have a bunch of technology or who just want some additional storage in their pack. Main compartment.
There may be, okay, great. Wanted to make sure that wasn't a comment. All right, but I just want to highlight that for substance use treatment, you see better outcomes in terms of reduced methamphetamine use, but you also see better outcomes in terms of their engagement in adherence to HIV treatment. So as Amu mentioned, there are only 2 treatments recommended by NIDA for methamphetamine use disorder, and the first being contingency management. So there are at least half a dozen meta-analyses that demonstrate that contingency management has a medium effect size, and a comparable treatment in terms of effect size is cognitive behavioral therapy. And when you compare these 2 treatments against each other, the effect size is, negative 0.02. So essentially no significant difference between these 2. So it really does come down to implementation considerations and the capacity for different settings to be able to implement either treatment. But I'll be talking about contingency management today because I do have a pilot study that will be launching soon that builds on the success of previous in-person contingency management protocols. So for those who aren't familiar with the ins and outs of contingency management, it's a treatment that requires patients to come to clinic 2 to 3 times a week. And that's typically a Tuesday or a Friday or a Monday, Wednesday, Friday. The idea being that you are testing them for methamphetamine use through urine sample collection. And that sort of schedule allows you to detect methamphetamine use throughout the week. Now, if the patient supplies a urine tox screen that is not reactive for meth, you then provide them with positive reinforcement. And so there are multiple ways that this positive reinforcement can be applied. A very popular approach is what we call this voucher-based procedure, which essentially every time they have a meth-free sample, they earn a voucher that could be exchangeable for either merchandise or for gift cards. And they have the possibility of increasing how much they earn per urine screen with consecutive meth negative samples. So on the table here, you see that on week 1, the very first Tuesday, if they supply a negative meth urine screen, they get $2. If they also supply a meth negative sample on Friday, that's what they earn increases to $2.50. And if they happen to have both meth negative screens on the same week, they get a weekly bonus. So the week 1 maximum earnings could be $14.50. And this, as you see in the table, increases over time for a maximum earnings of around $372. But I want to say that's only if they had all 24 urine screens negative. So that's typically not the case. So the amount that people earn is generally a little bit smaller than that. But I do want to make that note that these values are actually quite small. And one of the concerns oftentimes is giving people a lot of money who are using meth or have risk for using meth, but these are kind of in real world setting, very negligible amount of money that they're earning. And then I want to make note that if they have a meth positive or a meth sample, they don't receive a voucher for that day, and they are set back to basically week 1's earning potential. So the next meth negative sample they provide is worth $2, and they build their way up. But if they have 3 in a row, they get to move back to what their pre-positive sample value was. So there are some important principles to follow when implementing a contingency management program. We do see when these principles aren't followed that the effectiveness of the intervention is reduced. So It is a therapeutic intervention that relies heavily on positive reinforcement as a learning principle rather than punishments. And that's really to help patients experience accomplishments more so than failure. We typically only target one substance of abuse. We find that oftentimes it can be a little bit defeating for patients if they're struggling to be abstinent from everything, or if they simply don't want to be abstinent from all substances. We do see, though, that if we only target meth, we typically do not see an increase in use of other substances. We do know that positive reinforcement has to occur immediately after the desired behavior, and that there really shouldn't be a lag. And this, I think, is where a lot of contingency management programs have failed, is when the positive reinforcement hasn't been applied for a week or months. That learning between, I supplied a sample that was negative and I got reinforced, that's a harder association to help patients learn if the positive reinforcement's not immediately applied. The positive reinforcements have to be considered valuable by the person. So at Owen Clinic, we are exploring issuing gift cards, which gives patients the ability to really select what sort of gift card that they find desirable. And that escalation is important. So the longer someone is abstinent, the more chances or the higher the voucher amount becomes. So this is a systematic review of individual differences in response to contingency management. So on an individual level, those who actually report a desire to stop or reduce methamphetamine use perform better in this treatment, as well as those who don't have any past use of benzodiazepines. And we find that people who actually have antisocial personality disorder, a history of sexual abuse, as well as a history of major depressive disorder, do really well in contingency management. When we look at other demographic factors, like if they were positive or negative for meth at baseline, or what their age is, older versus younger, or their delayed discounting behavior, we see that there's mixed evidence. Some studies show that those individuals do better in contingency management, whereas some studies show that they do worse. So we don't really have any concrete evidence to suggest a firm directionality. And in terms of other factors that don't seem to play a role in treatment outcomes for contingency management, we have things like other use of substances like cocaine and cannabis, and alcohol use that doesn't seem to impact treatment outcomes, as well as psychiatric symptom severity, any legal problems, race, ethnicity, sex, or income levels. So when implementing contingency management, I want to acknowledge the strengths, which are the established efficacy of the treatment. It is a treatment that patients find to be highly acceptable. And I think one of the strengths, some people might think this is a weakness, but it targets a specific behavior. I think a lot of times in psychosocial interventions, there's a lot of behaviors that are targeted, and that sometimes is very helpful if patients are highly motivated and those behaviors can cluster together. But for others, it can be just too many things to be monitoring. So the simplicity of it, I think, does a nice job for really highlighting a specific goal and being able to monitor and assess a specific goal and people's progress toward it. As a behavioral treatment, it can be delivered by non-specialists. And I think that's a big time strength, as there aren't enough clinical psychologists. So when we can get non-specialists to deliver an intervention, I think that's definitely a strength. And clinic visits are brief. It can be delivered independent of a group, as well as it can be delivered in the context of an existing group. So that flexibility is key for clinics that may not have the resources to have a full-blown substance use treatment program. The weaknesses, though, are worth noting, which is you need to identify a funding source to cover the cost of reinforcements. So there are some insurance companies that will provide coverage, but only up to $75 worth in incentives. And that really doesn't allow providers to provide contingency and management in a way that it's been tested. So, you know, it really isn't giving us the opportunity to use insurance coverage as a reliable source of funding. Traditionally, it does require people to come into clinic 2 to 3 times a week. And for many people, that's difficult because of transportation needs, work conflicts, or just simply the difficulty and hassle of getting to a clinic that frequently. And in terms also of insurance coverage, oftentimes we do have a max number of people we can serve in a group, with the maximum currently being 8. So that does limit the overall reach of these interventions. And then I also want to acknowledge that there are some negative perceptions of contingency management that do persist. So similar to the HIV care continuum, substance use disorders, the field of it has developed its own cascade of care model. And I wanted to just show this briefly to highlight that we estimate that there are about 22.5 million people living in the United States with a substance use disorder. And when we look at those who are actually receiving treatment, we find that only about 12%, and that is any sort of treatments, not necessarily an evidence-based treatment. So what's mixed in with this number are those who are receiving detox, which in itself is not effective for helping someone reduce their use. And so similar to the ongoing efforts to help people engage in HIV treatment effectively, there are ongoing efforts to really help people better engage and access substance use disorder treatments. So that's where my K23 project steps in, where I am going to be piloting a smartphone delivered contingency management program. So before I talked about the logistical considerations for in-person contingency management, which typically requires patients to come to clinic 2 to 3 times a week, with the smartphone delivery of contingency management, patients are mailed saliva kits that are capable of testing for the presence of methamphetamine metabolites, and also has people download an application where they can video record themselves taking the saliva sample and then showing the results. And if it's negative, they have this Smart Visa debit card where the amount that they earn for that substance-free saliva test is automatically debited onto their account. And then the Smart Visa debit card does restrict where they're able to spend their money. So you can say that there are certain places or vendors that are acceptable and others that are not. So Dynamic Care has been funded over the years through major support from NIAAA as well as NIDA and other independent states. It's been currently investigated by over 30 scientific investigators. And we're seeing that Medicaids, at least in Vermont and West Virginia, are already covering patients for this smartphone delivered contingency management program. So my objective really is to pilot this in Southern California and see and test the effectiveness of it and whether or not it leads to better patient outcomes in terms of substance use as well as HIV outcomes to really support its coverage by Medicaid in California. So how this application works. So it's currently offered as a 12-month program. Patients can be referred to the program through multiple sources. So through their payer referrals, provider referrals, or direct marketing. There typically is a triage page on the Dynamic Care website and a dynamic care staff member assesses the patient's needs and triages them. And during that time, they're shipped the equipment that they need to be able to use dynamic care. And then dynamic care offers weekly check-ins with a recovery coach and 12 months of continuous care. So what that continuous care looks like is for the first 4 months, they receive these motivational incentives, which we know as contingency management. And then after that 4 months, the treatment shifts such that they are then engaging more and more in self-guided cognitive behavioral therapy content that is offered through the app itself, as well as through the weekly one-on-one meetings with the recovery coaches. But through this entire 12 months, patients are routinely doing the substance testing to assess whether or not they have any recent methamphetamine use. So there has been some publications related to this smartphone delivered contingency management program. One that I'm highlighting today was conducted among 85 patients with opioid use disorder, and they received this treatment for just 4 months. And they compared those who received the smartphone delivered contingency management to patients who received in-person contingency management at a nearby clinic. And what they found was that those who received smartphone contingency management had a higher likelihood, an odds ratio of 4.84, for an increased proportion of having substance-free urine samples at the 4-month mark. They also saw that those who received contingency management via smartphone were more likely to attend appointments, as well as more likely to consistently provide samples. So in the study that we'll be launching, our aim is to conduct a hybrid type 1 pilot study of the smartphone delivered contingency management. And we have 4 main outcomes that we hope to evaluate. So the first hypothesis is geared around implementation outcomes and testing whether or not the smartphone delivered contingency management program will be rated as acceptable, appropriate, and feasible by patients and providers. Our second hypothesis is around service outcomes. So we hypothesize that patients with HIV who engage in contingency management will have a high proportion of meth-free saliva samples. Our third hypothesis is around service outcomes as well, which is that we hypothesize a higher proportion of patients with HIV who engage in the smartphone delivered contingency management program will be better retained in outpatient HIV care. It's not exactly the same outcome as you would see monitored by the CDC. This one we're measuring with no-show rates at Owen Clinic. And then our exploratory hypothesis is that a higher proportion of patients who engage with the smartphone delivered contingency management program will have suppressed HIV, and we'll continue to follow them after they've completed the 12-month contingency management program. So to be eligible for this study, patients need to be age 18 or over with documented HIV. We ideally are trying to recruit from the Owen Clinic, and we will monitor our recruitment targets to see if we need to expand outside of Owen Clinic, but that is our initial study sites. Patients need to have a moderate to high risk score on the assist, have interest in reducing meth use, be English speaking, and able to provide voluntary informed consent. We are still working on the power analysis, but generally we are targeting between 40 and 60 patients for this study. As they go through this 12-month study, they will be completing brief assessments every 4 weeks through the Dynamic Care Health app. And those assessments will be focusing on things such as consequences of meth use, their functioning in major life domains, quality of life, depression symptoms, and sexual behaviors. And then we will also be deriving variables from the electronic health records, such as their demographics, their ART prescriptions, as well as any existing psychiatric and substance use diagnoses that they have. This is a hybrid study, so we are interested in implementation outcomes and measures. So this will be guided through an implementation framework called the EPIS, as well as using the Proctor implementation outcomes to guide our evaluation. And along the way, the implementation team will be tracking the implementation strategies that we're using to better integrate this into the care at Owen Clinic. So the timeline being that we are submitting the IRB now, so hoping to be able to start study recruitment pretty soon, as soon as we get approval. And that study recruitment, we're targeting 18 months. And this will allow us to either to be able to recruit between 2 to 3 patients per month to meet our recruitment targets. So that is the end of my presentation. I'll stop sharing my screen so I can see the questions in chat.
Great. Thank you, Jessica. So there was one initial question from Vernay asking about for dynamic care contingency, do patients need to have a smartphone or do you provide them one? And also, has lack of housing historically been a barrier to care?
Yes, so that's an important consideration. They do need to have a smartphone. We do have the ability to provide someone with a smartphone. We still need to figure out the best ways for rolling that out. In previous studies, we've allowed people to have one replacement. And after that one replacement phone, we've said we're not going to be administering any additional phones. It is common for people to lose phones or for phones to be stolen. Our hope is that if they see that, hey, by having contingency management on my phone, I'm receiving these rewards, maybe there will be a higher retention of cell phones. But preferably people will be using their own cell phones. But if they don't have one, we're able to provide a couple.
Great.
And then in terms of the homeless question, yes, that definitely, for at least in person, makes it very difficult for people to show up in person at clinic and be able to routinely do these urine samples. For some people, even those who are homeless, they find that it provides them with nice structure throughout the day, but that's not everyone. So we're hoping to be able to track that as one of our demographic variables to see if there are any differences between those who are homeless or not in their ability to engage effectively with this smartphone app.
And I think Vernay followed up, thinking of the kit having to be mailed to their home.
Yes, so with that, not everyone's going to have a place for it to be mailed or want it to be mailed there. So we will likely offer them to have it mailed to the HNRP, which is just 2 blocks away from the Owen Clinic.
All right. Looks like there was another question. Will patients still be seeing their regular substance use treatment team at UCSD or any other site, or will they only have access to the company therapists and coaches?
We'll still have access to their Owen Clinic treatment team. So if they were already seeing any of the substance use treatment providers at Owen, they should continue to see those providers.
Great. Any other questions? Feel free to unmute or raise your hand. I see Darcy has a question. Now she can't unmute herself.
I just did an applause. That was a great talk.
Oh,
and a
that
nice,
was okay.
Complimentary of topics covering both sides of this.
Thank you, Darcy.
Any other thoughts, comments? think there were some other chat about kind of continuing on the question about the GI side effects with the bupropion naltrexone. I don't know if Shannon, if you're able to come on and maybe comment on that.
Sure. I was just trying to look into to see if I could try to tease that question out for you, Darcy, about, the GI side effects, if they're similar with the intramuscular naltrexone. Like I put in the chat, there definitely were higher rates of GI toxicity in the study for methamphetamine use disorder. I was looking, the question of, well, could some of them be going in, could that be exacerbating opioid withdrawal potentially? I know meth withdrawal doesn't have a ton of GI side effects. Usually, occasionally we'll see people with diarrhea, but it's not like the, severe GI upset. So I was looking at that study. They didn't explicitly exclude folks with opioid use disorders, but they had to be, quote, opioid free at the time of randomization. And then they also were excluded if they were on concomitant treatment for substance use disorders already. So you would think that might have screened out for a lot of people, but I think it's still possible that some of them may have been, having some opioid withdrawal that then could have been exacerbated by the naltrexone. Obviously, the Wellbutrin can also cause some of that. So I think the long story short is we'll probably have to just watch out for these symptoms and help manage patients through, because it is a pretty decent amount of patients, at least in the studies, that had some GI issues on that treatment. So something to watch out for regardless.
Well, and it's also not right. This study was using long-acting injectable naltrexone, which a lot of people don't necessarily have access to, providers and patients. And so I don't know if anyone knows if the study's been about oral naltrexone and using it in combination with bupropion in terms of treating meth use disorder. But that is just the logical leap that my mind went to in terms of what could I actually practically start doing tomorrow. Or even thinking about starting this in the hospital, where I don't think Vivitrol, is on formulary. Maybe it is, but
no, it's not. And we've talked about that on a lot of patients where we've just initiated the bupropion at least, and then with the plan to initiate the Vivitrol in clinic post-discharge. But it's an interesting question. A lot of them are getting PRN opioids in the hospital for whatever their acute issue is. So a lot of the times that is kind of the limiting factor, or we're concerned that they might need to, based on what's going on. But we could certainly start trying it. I don't know, get it on board at least. I could kind of see both arguments. It wasn't studied with the oral version, but then, the sooner we can get people on therapy while they're in our care, the better. So I don't know if anyone in the group has any thoughts on initiating oral, as a bridge till we can get the Vivitrol for them.
And I think that was the question Amu was asking. Well, how about oral naltrexone, et cetera? So, but I think for sake of time, one last question. Have you considered making the monetary reward exponential rather than increasing at a linear rate of $1 per week, similar to rodent models, setting up fixed ratio for you obtains no reward?
Yeah, that's an excellent point. I do think that those sort of schedules for reinforcement could potentially be more rewarding over time. We so far have taken the approach of following what's been done in San Francisco through their PROP program, because their program has run for so long and been quite successful. But there have been other contingency management investigators who have used these other reinforcement schedules. I will say that dynamic care tends to be more on that exponential schedule. So we may actually see that that's kind of a confound between those who receive inpatient contingency management versus those on the app. So that's something that, as we're implementing in-person contingency management at Owen, that we might want to revise, but also kind of keeping costs in check.
Great. So it's 9 o'clock. I think we'll go ahead and end here, but I wanted to thank Drs. Rajagopal and Dr. Montoya for their excellent presentation. we hope to see you next week, and have a great weekend. Thank you.
Thank you.